At the outset, I would like to thank Dr. Divyansh and ma'am for giving me this opportunity. So I will be discussing a few acronyms. So I will be discussing each cases. Like is the case one, a 58-year-old gentleman presented with 618 vision in the left eye, and he had proliferative diabetic retinopathy. We can see on OCT there is no macular edema. The outer retina is normal, but what we can see is in this half, that the nasal half, we see that the individual layers of the retina can be differentiated from each other. But whereas in this temporal half, we can't make out the different layers like from each other. We can't make out that there are different layers. It appears more often homogeneous one. So this is termed as drill or disorganization of retinal inner layers. So why we need to know this? Because as we can see over here in this case, we can see that the temporal half shows areas of ischemia. So there are a few publications which even have noted that correspond to the area of macular ischemia. So how it can help us is it's a surrogate marker of macular ischemia. So those who don't have an OCTA or don't want to do an FFA in a case, macular ischemia can be, it's not definitely a macular ischemia which we can identify an OCT itself, but drill shows that it is probably an area of macular ischemia. So it's a surrogate marker that explains the poor vision in this case, which is 618. So moving on to another case, in this case it was a stable PDR following PRP with center involving DME. Here we can see that this part we can make out the layers differently, but in this half, the supratemporal half, what we are seeing here doesn't show that different layers as distinct layers actually. So post treatment we could see that there was a good resolution of macular edema, but the vision didn't improve much. So again, drill is an indicator of functional outcome, a poor functional outcome. In this case, there is an additional component of outer retinal loss also, which can be even contributing. So again, what we need to understand is like it's a biomarker of poor functional outcome. So moving on to another case, a 58-year-old gentleman presented with a central retinal vein occlusion with a cilioretinal artery occlusion in his left eye. So he was one-eyed. At that time we could see that there is area of retinal whitening which is corresponding to the area of cilioretinal artery occlusion, but even in other areas we could see that there is a hyperreflective band at the level of outer plexiform layer. So this hyperreflective band is termed as the prominent middle limiting membrane. So why we need to know this? So this case in future developed recurrent edema over a period of 16 months, received 12 anti-VEGF injections, also developed a rubeosis iridis after 12 months, and he was treated with PRP and he still continued on anti-VEGF therapy. So the prominent middle limiting membrane indicates that it's ischemia. The patient presented with a relatively good vision and not much of an edema at the beginning, but we could see that prominent middle limiting membrane in the entire macula, which may be an indicator that there was a significant ischemia to this case. So moving on to another case, a 61-year-old lady with a moderate non-proliferative diabetic retinopathy with DME with a vision of 6/60. So like here we can see that at the fovea there was a cystoid space with hyperreflective material lining the inner wall of the cyst. So this is termed a pearl necklace sign. This is not an acronym. This is the only entity which is not an acronym in this presentation. But Dr. Divyansh asked me to include this, so I have included it. So like post injection, like with triamcinolone in this case, like we could see that there is precipitation and aggregation of this hard exudates at the center. So like and the patient actually maintained a vision of 660, did not show any reduction in vision, but it has been reported that like presence of pearl necklace sign can be considered as a marker for a risk of hard exudate precipitation and vision loss following therapy. There are a few cases like small series in which they have noted that those with pearl necklace sign have developed vision loss due to precipitation and aggregation of hard exudate at the center of fovea following injection. Moving on to another case, a 54-year-old gentleman with moderate non-proliferative diabetic retinopathy with DME. On OCT, we could see that there was neurosensory detachment at fovea with macular edema, and we can see that there was hyperreflective rim with a hyporeflective lumen, which corresponded to aneurysm with the white rim. So what is it like? It has been termed as a retinal cap. There are various terminologies which are used to describe this. So a similar looking entity has been described as retinal capillary macroaneurysm by a few authors, telangiectatic capillaries by a few authors, and in idiopathic conditions has PVAC, peripheral exudative vascular anomalous, perifoveal exudative vascular anomalous complex. They are not really significantly different from each other. Most have a similar clinical characteristics. So in this case, the patient didn't respond well to bevacizumab. Like we gave bevacizumab 3 doses, he didn't respond well. Then we treated the lesion with laser photocoagulation, and we can see that there was a complete resolution of macular edema, and that entire area was replaced by homogeneous hyperreflectivity, and there was no recurrence till 6 months follow up. So what we need to know is, like, they can be identified on clinical examination and can be confirmed on OCT. They are a biomarkers of poor response to anti-VEGF therapy and reasonably good response to steroids and very good response to laser. Case number 6, a 42-year-old gentleman with myopic choroidal neovascularization. What we can see is there is subretinal fluid. At the same time, there is split in outer fiber of photoreceptor cell. So this is called the bacillary layer detachment. So bacillary layer is basically the uh, inner and outer segment of photoreceptor. That's termed the bacillary layer detachment. And when there is a split in between them, then it's called a bacillary layer detachment. So it can be seen in a lot of conditions, like as it is mentioned over here, but as of now we don't know like whether it has any clinical implication. Thank you.
Thank you very much, Pradeep. I think very nice demonstration.